So hello everybody. So we are starting with neurophysiology, right? So the first important topic that I can say in neurophysiology is descending motor pathways. Okay, so whatever pathways we are going to learn, since you are new to the pathways, I would like to give you an introduction of how a pathway has to be studied and what are the components of a pathway. Because I would like to just give you one piece of advice here. You can take it as a advice or a piece of information or suggestion, whatever. But I strongly recommend you all to follow this, because other chapters, if you take, okay, from exam point of view, we can study, we can pass. Okay, so we will not come across cases very often, though we come across, but not that often. But if you take neurology, we have everyday cases coming in general medicine posting, be it a government college or a private setup. Everywhere we have neuro cases in medicine department, and if you go and check, we are having cases only related to lesions in the pathway. If you remember me talking about facial nerve, I would have told you about lesions, what is a lesion, upper motor neuron, all that, right? So you need to get your minds ready to just take in some more important information about presentations shown by a patient. So for understanding why the patient shows these presentations, you should understand the pathway. That is why we are here. So I would like to start with the pathway. So motor pathway. So I would just like to give you an introduction. I would just like to take you step by step, because if I'm going to directly talk on the topic, you will not understand anything. So I'll just go step by step. So the first thing you should understand, see, we have two pathways, friends. We have a motor pathway, we have a sensory pathway. Okay, so if you take sensory pathways or ascending pathway, which means they are going to arise from a structure which is at the bottom, and it is going to come and reach the destination which is at the top. Okay, so top in the sense, what is the destination? It is going to be your brain, right? So sensory pathways are always ascending. Okay, and the set of fibers that constitute the sensory pathway is called as an afferent, AFF fibers. Okay, so if somebody says sensory pathway, you need to understand two terminologies. It is an ascending pathway, it is an afferent pathway. Okay, so afferent pathway, ascending pathway. Similarly, if you take a motor pathway, it is going to be a descending pathway, which means it is going to arise from the cortex, from the top, and its destination is going to be somewhere in the bottom. So it can be a spinal cord, it can be at the level of brainstem, or it can be a muscle. So anything. Okay, so there is going to be a structure at the bottom. Okay, so that is a descending pathway. So if you take motor pathway, mainly we will have only two destinations, brainstem and the spinal cord. We'll be studying in detail, but I want you all to understand this basic concept. Okay, so motor pathway, if you take descending pathway, and it is an efferent pathway. Okay, so sensory we have seen, so two terminologies starts with A, ascending pathway, afferent. Motor pathway, if you take descending pathway, efferent. So this is the first thing that you must know. That is why if you take, my title itself says it is a descending motor pathway. Okay, now we will move on to the next part. So if you take, what are the two main components that is involved in any pathway? Is one is your brain, another one is your spinal cord. So the pathway that we are going to talk about, that is on descending motor pathway, is mainly going to involve two primary structures, that is your brain and your spinal cord. Okay, now what are the components of brain? That is, one is your cortex, another one is your brainstem. So fibers can either arise from your cortex, or there are some fibers which arise from the brainstem. Okay, and it is going to travel to the spinal cord, and from the spinal cord it goes to the muscle. So the set of nerve fibers or the set of neurons that are present right from the brain to the spinal cord is called as an upper motor neuron. What is it called? It is called as an upper motor neuron. Very important concept. The basic first concept that you must understand in any pathway is, what is an upper motor neuron, what is a lower motor neuron. What is an upper motor neuron? Till the spinal cord, the set of neurons that arise from the brain to the spinal cord, it constitutes the upper motor neuron. And from the spinal cord, you are going to have some set of nerve fibers that is going to go to your muscle, most probably here if you take motor pathway, right? So this constitutes your lower motor neuron. Okay, so the first concept that I gave you was on what is a sensory pathway, what is a motor pathway. The next concept that I am covering here is about what is an upper motor neuron, what is a lower motor neuron. So if you take upper motor neuron, the set of neurons that is going to be present right from the brain to the spinal cord, it is an upper motor neuron. And the set of neurons that is going to be from the spinal cord to the relay center, I mean to the effector, not relay center, to the effector. Okay, so be it a muscle or a receptor, whatever. So since here it is a motor pathway, I can very well establish that the effector can be a muscle. Okay, it is a lower motor neuron. So you have an upper motor neuron, you have a lower motor neuron. I hope you all have understood what is an upper motor neuron and what is a lower motor neuron. So now we will move on to what are the motor areas present. So this is how you need to study, ma. Okay, so first you should know what it is. Okay, and what are its constituents? So we have an upper motor neuron, we have a lower motor neuron. Now we are moving on to the proper topic, that is your cortical motor areas. So before going on to any pathway, you should first understand what are the structures that are involved in a pathway. Now here I have told you we have brain wherein we have cortex, we have brainstem. So am I trying to confess here that the entire cortex is going to involve in the pathway? Absolutely no. There are going to be some specific areas in the cortex that is going to involve in a particular function. Okay, I hope you all would have studied in your anatomy in cerebrum. There is an anatomist called Brodmann who actually classified the brain into numerous areas. Okay, so we'll be studying some of them now. So if you take what are the motor areas of the cortexes, we have three motor areas. We have something called primary motor cortex. We have something called as a premotor cortex. And we have something called supplementary motor cortex. So the three cortical motor areas, we have a primary motor cortex, we have a premotor cortex, we have a supplementary motor cortex. So what are the points you must understand about this motor areas? Is first thing what you must understand is all these motor areas are concerned with the frontal lobe. Okay, so majority of the motor areas are going to be only in the frontal lobe. And the second thing, all the motor cortex are going to be in front of central sulcus. So if you take this plane, so you somewhere here you will be having your central sulcus. I hope you all know what is a central sulcus. To revise what is a central sulcus, okay, that is it is going to arise from your Sylvian fissure, which is going to be laterally. Okay, so you have lots of fissures in your brain, right? So if you take this central sulcus, it is going to arise from the lateral surface. That is going to be, you have a fissure called Sylvian fissure. Okay, so I'll just mark here. Okay, this is a Sylvian fissure. So from here you have a fissure that goes to the top of the brain. Say suppose here you have your Sylvian fissure. It goes to the top of the brain. And it is going to be continuous with your median longitudinal fissure. Okay, so you all know what is a sulcus and what is a gyri, right? So there is going to be an important landmark called as central sulcus, which originates from your lateral Sylvian fissure. It goes all the way upwards to the top of the brain or apex of the brain, and it is continuous medially with your longitudinal cerebral fissure. Okay, so all these motor areas that I am discussing is going to be anterior to this central sulcus, or it is going to be present in the frontal lobes. Okay, so what I have told you the three motor cortical areas and I have told its location. Why am I repeating all this continuously is because since it is new topic for you, you may not understand that much. So that is why I am repeating so that you can understand in a better way. Okay, so we have three motor areas. Okay, so we will just see something about the motor areas. So before that, I hope you all are clear with this. So this thing is done. Okay, so I have told you what is an upper motor neuron, what is a lower motor neuron. So till spinal cord is upper motor neuron, and from spinal cord to the effector it's a lower motor neuron. And we have seen the cortical motor areas. In cortical motor areas, what are the structures that we saw? We saw what is the central sulcus. What is the central sulcus? Sulcus which arises from your lateral sylvian fissure. It goes to the apex of the brain and it is continuous with your median longitudinal cerebral fissure. And anterior to the central sulcus, we have certain important cortical motor areas. What are the important cortical motor areas? We have primary motor cortex, we have premotor cortex, we have something called supplementary motor cortex. So all these areas are responsible for whatever motor movements that we are performing in our day-to-day life. Okay, now we will just see something about these cortical areas. So as I told, we have a primary motor, we have a premotor, and also we have something called supplementary motor area. I have not included them, but I will anyways tell you the function alone. So I told you there was a very great anatomist called as Brodmann who understood the entire cortical region and he divided the cortex into many areas based on the function. Okay, so you have something called area number 44 that is called as a Broca's area, and for your auditory cortex there is some areas. Okay, and for your visual cortex there is some areas. Okay, that is Brodmann. Suppose this is the cerebral cortex. He was just able to divide the cortex into many areas. Like if you take in our locality itself, we will have many streets, right? So we will be in one street, our friend might be in another street. So an area, that is, I can say a locality is divided into many areas. Same way, a locality called cerebral cortex is divided into many areas. Okay, so such areas are called as Brodmann's area. So you have Brodmann's area 4, you have 6, you have 44, 45, 19, 18, 21. So you have numbers that is present all over the cortex. Okay, so this primary motor cortex, which we saw just anterior to the central sulcus, if you take this blue color is your primary motor cortex. So this corresponds to Brodmann area 4, an important MCQ. Okay, so you have primary motor cortex that is belonging to Brodmann area 4, which means according to Brodmann, he had a area called 4 in the cerebral cortex that corresponds to primary motor cortex. What is the function of primary motor cortex? It controls the fine execution of motor movements. See, always remember, we'll be studying in cerebellum. You will have initiation, you are going to have execution. See, there is a thought that you need to initiate a movement and there is going to be execution. Okay, see, I'll just tell you with an example to make you understand. See, you are having an exam next week. Say, suppose you have an exam. Okay, so you have 1 week time. So what you will do? Last test I did not do. I should do something. You will plan everything. If I do according to this plan, I'll get sent up. So you plan everything. Okay, so this is called initiation. But what we ultimately do, most of us, we fail. We fail to, we do not fail in exam. Sorry, I'm not trying to tell that. We fail to move with the plan. Okay, so what we say, suppose we plan a 3 hour study. Half an hour we will study. We'll get a notification on Instagram. We will go there. We'll spend 1 hour there. Then come back. Then go there again. So your initiation was excellent. But what happened? Execution was not proper. This usually everybody says, right? So same thing like what happens with our exam preparation, for a motor movement to be happening. So suppose you go hold a pen. That is a motor activity, right? So there is going to be initiation of this idea that you need to hold that pen. What is execution? How effectively you hold that, whether you drop the pen or you are able to hold it very tightly, that is execution. So if you take this initiation part, which is the very good part, is done by certain areas called as cortical association areas. Okay, so if you take in your cortex, you are going to have some association areas, which means areas associated with the cortex, right? Those are called as cortical association areas. So these cortical association areas are meant for initiating a motor movement. Okay, which means it is just going to process the motor movement. Okay, I can say initiate. Fine execution is by your primary motor cortex. Very important point to understand. Okay, you framing timetable is by cortical association area. You effectively preparing according to the plan is the execution. Okay, so let's correlate with this. So primary motor cortex, which is related to the Brodmann area 4, is responsible for controlling the execution of a motor movement. If there's execution, there has to be some structure which is involved in initiation. So initiation of these motor activities is by your cortical association areas. Okay, please make a note of this point. Similarly, we saw another area called premotor cortex, which was anterior to the primary cortex. So that belongs to Brodmann area 6. Okay, setting the posture before movements. Setting the posture before movements. We'll just take example of what cricket. You take an example of cricket. So you try to actually, okay, so say suppose 10 balls, 2 runs to win. So you will try to have a different way of batting, right? So you just have some balls to be dotted, or you, like MS Dhoni, you try to do a winning shot. So you go front foot, you just swing the bat. Okay, so before you do any movement, you are going to set a posture. Okay, I need to bend my legs this much. I need to cross the grease so that I have a front foot. Okay, or if you try to know like ABD, you try to turn through the 60-degree. What you're going to do? You're going to rotate yourself. If you observe this ABD batting, I can just give you the best example. ABD Williams batting. The moment the bowler takes his arm above his head, ABD will start coming. He'll like walk from left to right because he's trying to set a posture there. Before swinging his bat 360-degree, he sets a posture. How he is able to set his posture? Because his premotor area is very strong. Okay, similarly, you try to hit someone. Okay, so you set a posture. You show all your arms. You be very comfortable so that the slap can be very tight. Okay, so all this is done by your premotor area. Premotor cortex. So premotor cortex corresponds to Brodmann area 6, which is responsible for setting the posture before movements. Okay, so this I gave you an example of timetable. Here I gave you an example of cricket, ABD, MSD, all legend examples I have given you. And I told you there is one more thing, right? Supplementary motor cortex. See, this supplementary motor cortex is also part of Brodmann area 6. But if you take its function, there is something called as bimanual coordination. Bimanual coordination, which means, see, there are activities that actually require support of another limb. Say suppose you write. Okay, you write something. So if you are right-hander, you are going to write with your right hand, but your left hand will be in some position that will make you comfortable for writing. I hope you all understand what I'm going to tell. Some people will try to have their left hand in front of the desk. Okay, some people will tend to tie it backwards. Okay, some people try to have the left hand and the tie. So there has to be a bimanual coordination that gives you a comfortable position for an action to do. So there has to be a bimanual coordination. So both the limbs has to somehow coordinate with the activity for effective motor activity. Okay, that is for your supplementary motor area. So primary motor area, it is meant for execution of the motor movements. Premotor cortex, Brodmann area 6, setting the posture before movements, and supplementary bimanual coordination. So these are about your cortical motor areas. I hope you all understood. If you have any doubts, please be free to put it in the comment section so I can reply. I have tried my best to make it very simple and understandable. Okay, now we will see something about spinal cord that is necessary to understand the pathway. Still, we have not gone into pathway. Okay, from the next slide only we will be going on to pathway. So spinal cord anatomy we will be studying in detail. Okay, just I want to highlight on few structures like your dorsal on, lateral on, ventral on. We are concerned only with your dorsal on and ventral on. Dorsal on is going to be sensory. Ventral on is going to be motor. Just remember this point alone. Okay, so this is going to send sensory fibers. This is going to be related to your motor fibers. Okay, so ventral on is motor, dorsal on is going to be sensory. So whatever tracks we are going to see now will ultimately terminate in the ventral on of the spinal cord, and from there it is going to go to effector. You should understand this point. Am I clear? I'll repeat again. You have a 3 ons in a spinal cord: dorsal on, lateral on, ventral on. Dorsal on is concerned with sensory, ventral on is concerned with motor. since we are dealing with motor pathways, so whatever tracks or pathways that we are going to see is going to come and terminate in this ventral horn, and from this ventral horn only it goes to the effector. Okay, next some more important structures. So in brain, if you take, you will have an outer surface of gray matter, inner white matter. But in spinal cord, it's the other way around, as I have already told you. It is going to be outer white matter and then inner gray matter. Okay, so here you will have your gray matter, here you have your white matter. And this white matter, if you take, it is actually referred to as funiculus. Okay, so you have three funiculus: posterior funiculus, lateral funiculus, anterior funiculus. Okay, and this is called as your white commissure, and this is called as gray commissure. If you you will be studying in white fibers of cerebrum, what is a commissural fiber and all. See, everything is concerned with white matter. Okay, set off some nerve fibers, that's it. Okay, so you have a anteriorly present white commissure, and inside you have some fibers that is called as gray commissures. Okay, so you should know all this. So you should know what is a dorsal horn, what is a ventral horn, what is the meaning of funiculus. So what is a funiculus? Funiculus is collection of white matter, that's it. Okay, so if it is present on the posterior aspect of the spinal cord, it is called posterior funiculus. On the lateral aspect, it is called lateral funiculus. On the anterior aspect, it is called anterior funiculus. Okay, ventral means what? Front or anterior, I can say. So you have anterior white commissure, so commissural fibers in the white matter, and gray commissure. Okay, it is in the gray matter. So these are the structures that you must know. Okay, am I clear till this? Now we will move on to pathways. So what are the motor pathways we have? So if you take pathways, we have something called pyramidal tracts. We have something called extrapyramidal tracts. We will see why the name pyramidal tracts came. This is what is your short note. Okay, so this topic is usually a short note, and only pyramidal tract is an important short note for you. So I'll be covering only that point. Remaining things, we have nothing much to cover. Okay, so if you understand how to study this pyramidal tract now, all these tracts will be very simple. Okay, so if you take under pyramidal tracts, we have an important tract that is called corticospinal tract. Very, very important tract. Okay, we will be studying. And you have extrapyramidal tracts that includes your reticulospinal, vestibulospinal, tectospinal, and then rubrospinal. Okay, if you remember, I told you in the first slide, you descending pathways, if you take, we have two structures involved. You have a brain, you have spinal cord. And in brain, if you take, I told you, we have cortex and then brainstem. Okay, so set of nerve fibers arising from cortex. Okay, that's what is included in your pyramidal tract, what we call as corticospinal tract. But if you take other pathways that we saw, like the reticulospinal, tectospinal, all these are parts of your brainstem. Okay, so all those extrapyramidal tracts mainly arise from your brainstem. Okay, so this is what I want to tell you: corticospinal tract, extrapyramidal tracts, or reticulospinal, vestibulospinal, tectospinal, rubrospinal, not that important. Now we will move on to one important, very important short note. Okay, if you are going to draw a diagram and if you are going to just label the parts then and there, you will get full marks. Okay, you will not write stories here. Okay, this is a picture from Gaitan on the left side that I have, and this is a picture from Hindu Purana. Okay, so for exam point of view, I will prefer you to draw this because it takes less time. But if you are a good artist, okay, you have diagrammatic skills from birth, you can go with this also. It's all your wish. Okay, but we will start studying. I'll be explaining you only with Hindu Purana tract. Okay, content will be from Gaitan, picture will be from Indian textbook. Okay, so how are you supposed to study a pathway? See, always remember its origin. Okay, it's what are the structures that are contributing. Now you might ask, why did you teach me about the cortical motor areas? It's because for your motor pathways, these cortical motor areas are going to contribute from fibers, which means it is going to give some fibers, and ultimately it involves in the function of a particular thing. You're able to understand what I'm trying to tell. Okay, in a teamwork, you do a chart. Okay, there are 4 members, you do a chart. So one person would have collected the pictures, one person would have colored everything, one person would have presented the content. Okay, so you have division of labor among, or you have contribution by each group member that sums up to a whole activity, right? Similarly, if you take in pathway, overall we will study functions, but there are going to be specific areas that are meant for a particular function. That is why we saw motor areas. If you take, we saw what is the function of primary motor area? Execution. What is the function of premotor area? Posture. Okay, so altogether we'll study a function, but individually which particular structure contributes, that you must know. Then you should know the pathway, how it goes, where all it meets, and then what is the clinicals. Very important. Okay, so we will start. You can just take down this flow chart. I made it very simple. If you're going to write this flow chart, draw this diagram, you will get full marks. Okay, so if you take origin, it actually arises from cortex. Okay, so just understand this thing alone. It is not actually given in the slide, but it was given in Guyton. If you take in cortex, there is going to be a very unique cell called as Betz cells. Okay, I'll just write the spelling here. B-E-T-Z. Okay, so if you take your cortex, actually you have many layers that has to be studied. Okay, so we have layer 1, layer 2, and we have something called layer 5 and all. Okay, so there are many layers that anatomists usually study the cortex. So we need not know that much, but just understand your corticospinal tract from the cortex. It is actually going to arise from the layer 5 of cortex in a specialized cell called as Betz cells. Okay, so this is in general overview. Okay, so what are the contributions? So what is the origin? I can say it arises from layer 5 cortex Betz cells, and you are supposed to include this percentage. If you take 30% of the fibers are going to come from primary motor cortex. 30% of the fibers come from premotor cortex. And if you take 40% is from somatosensory cortex. This is actually, I can say, uncomfortable point. We are talking about motor pathway, but see, there is going to be a somatosensory pathway coming. There's some sensory cortex involving, right? So this is actually, I can say, a paradoxical point, but okay, fine. We just have to understand this. This is how the pathway operates. So we have 30% from primary motor cortex, 30% from premotor cortex, and 40% from somatosensory cortex. So since your guidance says Betz cells, how I can actually modify this point is, it arises from, right, all these 30% primary motor cortex, 30% premotor cortex, 40% somatosensory cortex, and you can say this tract arises from layer 5 of the cortex region, which contains cells called as Betz cells. So you can actually put this in a bracket downwards after writing all this. Okay, it's better you include this first and go with Betz cells. Okay, so if you observe this picture, this is your primary motor area, this is your premotor area, and this is your somatosensory area. This should be 6 actually. Okay, so primary motor area, premotor area, and then somatosensory area. So if you take, you have 30% of fibers arising from primary motor cortex, 30% of fibers from premotor cortex, and you have 40% of fibers arising from your somatosensory area. Okay, so then what is the point you will include? It all arises from layer 5 of cortex, which contains a cell called as Betz cells. Now after its origin, it is going to descend downwards, okay, to the posterior limb of internal capsule. Okay, so we will study what is an internal capsule. So if you take internal capsule, so it is actually, so I'll just tell you, you will have something called caudate nucleus, you will be having thalamus, you will be having lentiform nucleus like this. Okay, so the white fibers which is going to pass in between this is called as actually an internal capsule. Okay, so you will have something called anterior limb, you will have something called genu, you will have something called posterior limb. If you take, this is your posterior limb of your internal capsule. Okay, so after origination, it is going to be related to your posterior limb of internal capsule. If you want a better marks, you can say after origin, it joins with corona radiata and is related to the posterior limb of internal capsule. Again, this name is going to be new to you. Okay, so what is corona radiata is, this corona radiata and internal capsule, these are white fibers of cerebral cortex. We'll be having a separate session on white fibers of cerebrum. That time you'll understand even better. But now understand, you have corona radiata and internal capsule that are going to be part of a white fiber of cerebrum. So after its origin, it is going to receive fibers from corona radiata, and then it is related to your posterior limb of internal capsule. Somewhere here you have your internal capsule, and this is your corona radiata. Okay, so here you're having your internal capsule. Okay, so corona radiata and then posterior limb of internal capsule. So from the posterior limb of the internal capsule, it is going to enter into your brainstem. So you all know we have three parts of the brainstem: midbrain, pons, and medulla. So it is going to enter into brainstem. So it is going to come via your midbrain. You have then your pons, then you have your medulla. Medulla is very important landmark next. That is, at the upper part of the medulla, it is going to form a structure called as pyramid. What is the meaning of pyramid? Pyramid is nothing but collection of fibers. So if you take fibers from the left side, okay, and then fibers from the left side and fibers from the right side, they are coming and they are going to join together, right? So this is your pyramids. So in the upper part of the medulla, the fibers, they are going to form pyramids of medulla. Okay, so if you take in anatomy of medulla, you'll be studying the pyramid of medulla is an anatomical structure, which means we can easily appreciate this pyramid. Okay, so it is going to be externally seen. Okay, so what is a pyramid? It is this collection of all your tract nerve fibers. Okay, so it is going to take part in formation of pyramid of medulla. Okay, or this term I can actually call it as pyramid decuscation. What is it called? Pyramid, PY means pyramid decuscation. DECUSSA. Sorry, my handwriting is very bad. I'll just spell out DECUSSATION. Okay, decuscation, pyramidal decuscation. Decuscation is nothing but all this. Okay, whatever I told you, this joining of fibers and all that. Okay. So till this clear, origin, okay, then corona radiata, then posterior limb of internal capsule, then via your brainstem, and at your medulla, upper part of the medulla, there's going to be pyramidal decuscation of medulla. Okay, after that, in the lower part of the medulla, if you take, it is dividing into two, or you're able to appreciate this, it is dividing into two. I'll just take this half alone. Okay, just take this picture. I will just consider this half, which means I'm going to consider only one side of the cerebral cortex. So if you take this pyramid, so once all your pyramid decuscation happens, the fibers are going to divide into two. Majority of the fibers, around 80 to 90% of the fibers, they are going to cross the opposite side. If you take, this is your fibers arising from the left side of your cerebral cortex. So if you take, once the pyramidal decuscation has been formed, around 80 to 90% of the fibers, they are going to cross to the opposite side. They are going to cross to the opposite side. Okay, that is called as your lateral corticospinal tract, which means it is formed around by 80 to 90%. Okay, so Guyton says 80, Indian textbook says 90. Okay, so better you include both. So around 80 to 90% of the fibers are going to cross to the opposite side, and that is called as lateral corticospinal tract. Okay, remaining what is present, around 10%. Okay, remaining 10%, they descend on the same side. So if you take, this is your same side origination. Okay, so it is going to descend downwards on the same side, and that is called as anterior corticospinal tract or your ventral corticospinal tract. Are you able to understand? After decuscation, majority of the fibers, around 80 to 90% of the fibers, they cross to the opposite side. That is called as lateral corticospinal tract. Remaining fibers, around 10%, it is going to descend down on the same direction. That is called as anterior or your ventral corticospinal tract. So we will see what happens to lateral corticospinal tract. We'll see what happens to ventral corticospinal tract. Okay. See, ultimately, what I told you, all these fibers has to reach the ventral horn of spinal cord. Okay. So you need to understand how lateral corticospinal tract reaches your ventral horn, how ventral corticospinal tract reaches your ventral horn. That's it. Okay. First, we will see lateral corticospinal tract. So where is in the picture? So it is present here. Right. So lateral corticospinal tract, it is going to come downwards. If you remember me, I showed you a picture of spinal cord in the previous slides. I told you have something called what? Funiculus. If you remember, where it is. If you take, I told you something called funiculus, which is nothing but collection of white matter. I told you, right? So if you take, after forming lateral corticospinal tract, it is related to your lateral funiculus. It is related to your lateral funiculus. From lateral funiculus, the fibers are connected to the ventral on neurons by means of an interneuron. Okay, or it is also called as internuntial neuron. Okay, see what is this? I'll make you think very simple. See, you have an afferent neuron. Say suppose this is your afferent fiber. Okay, and here you have your efferent fiber. We'll just take this case itself, ma. Okay, so fibers from your lateral corticospinal tract is your afferent, and ventral on, the neuron concerned with the ventral on is your ventral. That means the efferent neuron. Okay, so this and this has to be connected somehow, which means the impulse carried by this neuron has to reach this neuron, but there is no proper direct connection, right? There comes a role of an interneuron that is actually going to connect both this afferent neuron with an efferent neuron. Okay, so interneuron is nothing but, to be very simple, it is a neuron present between two neurons. Able to understand, it's a neuron present between two neurons is called as your interneuron. So from your lateral funiculus, the fibers are connected to your ventral on or your ventral on cells by interneuron. So from interneuron, it goes to your ventral on. Able to understand, this is your course of your lateral corticospinal tract. Okay, so from lateral corticospinal tract, once it is formed, it goes to your interneuron, and from lateral corticospinal tract, it goes to lateral funiculus. From lateral funiculus to the interneuron, and from the interneuron to the ventral horn. So this is the lateral corticospinal tract. If you take ventral corticospinal tract, what is going to happen to the ventral corticospinal tract? Observe this picture. What is this called as? This is called as your anterior funiculus. This is a lateral funiculus. This is your posterior funiculus. So this is called as your anterior funiculus. So it is related to the anterior funiculus first. And if you remember the picture again, this is called as ventral white commissure, and this is called as gray commissure. Okay, so from one side, this ventral corticospinal tract, it goes to the ventral anterior commissure, ventral white commissure. It crosses the midline and related to the gray commissure and reaches the ventral on. Observe this course. This is your ventral on. Okay, this is your anterior funiculus. From anterior funiculus, it goes to your ventral white commissure. So this is your ventral white commissure. Then crosses the midline. So this will be your midline. If you take, I have drawn here, I'll just continue this. So this is going to be your midline. Sorry, it had gone cross. Never mind. Okay, so this is your midline. I'll draw again. This is your midline. Okay, so what is happening? From your ventral white commissure, it is going to cross the midline by related to your gray commissure. So from white commissure goes to gray commissure, crosses the midline, and it is related to your ventral on. So gray commissure and finally to your ventral on. And from the ventral on, you have your effector neuron going in, and it is going to supply the muscle. So this is your ventral root. Okay, this is your ventral root and this is your ventral on. So this is the course. So just close your eyes, just bring this picture. Okay, if you bring this picture, you can understand. So origin 30% from primary motor cortex, 30% from premotor area, 40% from somatosensory area. From there, it receives fibers from corona radiata and is related to your posterior limb of the internal capsule. From there, it comes to brainstem. In the brainstem, it crosses the midbrain, then the pons, then it comes to the medulla, where it involves in pyramidal decuscation. And after decuscation, around 90% of the fibers, it is going to cross to the opposite side, forming what is called as your lateral corticospinal tract. and remaining 10% of the fibers forms what is called as a ventral corticospinal tract. If we take this lateral corticospinal tract from the medulla, it is going to at lateral corticospinal tract, it then descends downwards to reach a lateral funiculus. From lateral funiculus, it is connected to the ventral horn by means of interneurons or internuncial neurons. Next, here we have your ventral corticospinal tract. It is related to your anterior funiculus. From anterior funiculus, it goes to the gray commissure. That is, it crosses the midline related to the gray commissure and finally reaches your ventral horn. This is your corticospinal tract. Now, what are the functions? Because if there is a lesion in this tract, the function of the tract is going to be lost, and that is what is going to be the presentation of a patient. Fine unskilled movements. Okay, so if you take these three group of functions are concerned with your lateral pathway, and this is concerned with your anterior pathway. That is your ventral corticospinal tract. So first we will see these are three important functions. Okay, so fine unskilled movements. Okay, which involves your writing. All these are fine and skilled movements. Okay, and this tailoring, all these will come under fine and skilled movements. Okay, so fine and skilled movements, muscle tone, superficial reflexes. We will have a class on superficial reflexes. So superficial reflexes, if you take superficially whatever you do, like your cremasteric reflex, abdominal reflex, corneal reflex, all these are superficial reflexes. You will be taught in practicals also. Okay, so all these are taken care by your lateral corticospinal tract. Main are fine and skilled movements, muscle tone, superficial reflexes, and whole limb movements is taken care by your ventral corticospinal tract. So these are the functions that you must know. So now, if a patient has a lesion in this corticospinal tract, what is going to happen? Fine and skilled movements will be lost. Muscle tone is going to become abnormal. Superficial reflexes are going to be lost. Okay, and limb movements are going to be affected. So if there is a lesion, all these are going to be affected. You need to understand where the lesion is. So we'll go on with the clinicals now. Very important. I want you all to listen to at this point very carefully. So we will be discussing lesions on few important landmarks. First thing will be your internal capsule. So if there is a lesion in internal capsule, what is going to happen? I'll go one by one. Please listen. If there is a lesion in the internal capsule, there is going to be a condition called as contralateral hemiplegia. What is it called? We have contralateral hemiplegia. Okay. You know, it's like jaggery, but never mind. Okay, contralateral hemiplegia. What is this contralateral? If you are all new to this term, see, contralateral means opposite. Ipsi means same. Okay, so contralateral means opposite lateral of ipsilateral means same side. That is the meaning, contralateral, ipsilateral. Now, this all will be new to you. Hemiplegia, paraplegia, quadriplegia. These are the three terms. Okay, I'll write here. HP, okay, QP, PP. Hemiplegia, quadriplegia, paraplegia. What is the meaning of hemiplegia? Hemiplegia means when complete one half of the body is paralyzed. Okay, that is called as hemiplegia. Okay, if quadriplegia means all the four limbs. Quadri means what? Four. So all the four limbs, two upper limb, two lower limb. If all these are paralyzed, then it is called quadriplegia. If lower limbs are only affected, it is called paraplegia. Hemiplegia, complete half of the body. Quadriplegia, all the four limbs. Okay, FOUR limbs. Okay, not FORE. All the four limbs. And then paraplegia means lower limbs. Okay, now if you take internal capsule, say suppose if a patient has lesion in the internal capsule, then he is going to present with contralateral hemiplegia, which means on the opposite side, superficial reflexes will be lost. Fine and skilled movements will be lost. There will be abnormal muscle tone on the opposite side. There will be complete paralysis. You will not be able to do movements at all, or the movements is going to be limited on the opposite side. Okay, so if patient comes and says to you, doctor, I am not able to lift my right hand and I am not able to no bend my right leg, something like this, you should suspect of what? This thing, left side lesion of internal capsule. Okay, so if there is a lesion in the internal capsule, patients present with contralateral hemiplegia. Now moving on with midbrain. If suppose say patient comes with lesion in the midbrain, which means somewhere here, what is going to happen is patient will present with contralateral hemiplegia, but ipsilateral third nerve palsy. What is that? Contralateral hemiplegia, but there will also be ipsilateral third nerve palsy. What is the third nerve? Third cranial nerve? Oculomotor nerve. So all your muscular movements of the same side of the eye is going to be lost. Okay. Third nerve palsy, because the third nerve nucleus is more related to your midbrain. So there is a lesion in midbrain along with this corticospinal tract. This third nerve is also going to be affected. So you have an ipsilateral third nerve palsy, which means the function of oculomotor nerve of the same side of the eye is going to be affected. Okay, so what you have here? Ipsilateral third nerve palsy. So contralateral hemiplegia with ipsilateral third nerve palsy is going to be lesion at the level of midbrain. Next, if it is at the pons. If it is at the pons, same concept, contralateral hemiplegia, because fibers are going to go to the opposite side. At the same time, you are going to have facial palsy ipsilateral side, because facial nucleus, we all know it is more related with your pons. There is going to be ipsilateral facial paralysis with contralateral hemiplegia. Okay, if the lesion is at the medullary level, there is going to be hemiplegia, no doubt. And apart from that, there is also going to be a ipsilateral 11th nerve palsy. So third, 7, 11. Remember, rule of force. Okay, so midbrain is at the top. So you start with 3, pons in the middle. So +4, 7. Then medulla again +4, 11. So 3, 7, 11. So midbrain, ipsilateral third nerve palsy. Pons, ipsilateral facial nerve palsy or facial paralysis, I can say. Medulla, there's going to be hypoglossal nerve palsy on the ipsilateral side. Along with, you will have this hemiplegia. Are you able to understand? This is what is the clinical. So if the patient comes and says he is not able to do all that and he is not able to rotate the eyes on the right side, you should suspect what? There is lesion at your midbrain. Okay, he is not able to exhibit any movements of face on one side. Okay, again you need to should think about corticospinal tract lesion at your pontine level. So this is what is the correlation. Please study like this. Okay, I have studied the entire track. I have studied the course. I am not done. Okay, when I will complete the study, only if I am going to include the clinicals. Okay, this internal capsule will be repeating again, white fibers. Again, that's my topic. I have taken that. Okay, so again we'll be repeating the same topic. We will see why the lesion is happening in internal capsule there. Okay, but now understand, this is what it is. Okay, so this is about your descending pathways. Okay, so if you have not taken this flow chart, you please take it down. This is more than enough for your exam. This is what I wrote in my exam. Okay, and I have drawn only this diagram that I have shown here. Okay, so if you have any doubts, okay, or if you want any kind of support from me to make you study neurophysiology, please be free to share in the comment section. Okay, neurophysiology will be tough, but once if you start understanding neurophysiology, if you are trying to correlate with clinicals and study, it is one of the most easiest, interesting topics to study. Okay, so I hope you all understood. We will meet in the next session. Thank you.